I'm gonna leave and then it's gonna stop.
It should be once I start flipping through the slides, right? Oh, is this even on? Let's try that. All right. Okay. All right. I'm going to get into right away just some tips and things about back pain that help that I think you can implement right, this week. If you don't know about it, prolonged sitting is probably the worst thing you could do. And here you are sitting for my talk. But there's 40 to 90% more compression on the discs and in your spine. And it's constant, when you sit, all that, it's going to a pretty small area as you're sitting. So sitting is the worst thing you could do. So if you can have a standing station, if you can set a timer and get up every 20 minutes, get up if you're watching TV, get up during commercials. But it is really one of the worst things you could do. And if you sit in bed, right? So you're sitting in bed with your legs extended, that's even worse. So anybody in here like to read in bed? Right. So I try to talk people into getting a chair in their room with back support and just, get a cozy blanket or something. But reading in bed is probably the worst thing just because of how slouched the low back is in that position. So please don't if you can avoid it. Sedentary lifestyle, that's another thing that makes it worse. So instead, try to get those steps in. Or what I like to call exercise snacks. So if every 20 minutes you can get up and at least do like chair squats or air squats, whatever you want to call that, calf raises, some lunges, whatever, like move, drink a lot of water. That will make you get up more often, right? Hydration really helps the spine and the disc. So you do want to hydrate. Stretching the low back is something that I'm not an advocate for. Most of us have more movement in the low back than we need. You might feel like it's stiff and you might feel like it's tight, but often that's the muscles just guarding the back. Stretching, I'm all for the upper back, the upper thoracic area, posture, your pecs, your shoulders, your hips are usually the problem. So if you have tight hips and you have low back pain, focus on those hips because that's usually the generator. The figure 4 stretch, I don't have a stool up here, but if I did, can you guys get like this? So you're just pretend I'm sitting. Can you get your leg in that position? Yep. And can your knee get down where it's almost parallel? Yeah. That might feel tight. If it is a little bit limited, that's going to put more stress on your back, right? So there's one that you can easily implement. Switch sides and compare sides, see if you're equal or if you're tighter on the other side. Oftentimes, whatever side you're tighter on is the side that you have more pain in the back with. So that's a great stretch, easy to implement. How many people have heard lift with your knees? Anybody? Come on now. Everybody. Thank you. That's actually incorrect, right? So, and the reason being, if you lift with your knees, typically what happens is you shift your weight forward. It's a lot of shear on my knees. Basically, lift with your hips. So if you can get your butt back behind you, your knees are still going to bend. So if you watch me from the side, if I lift with my knees, typically people do this. That's a lot of strain. If I get more of just my hips behind me, my knees still bend, but the bulk of the work now is in my hips and my knee doesn't feel any pressure. So we will practice that on the next slide. We'll get to that. But I basically want you to learn how to hip hinge when you lift and squat. It'll save your back and you'll save your knees. So we'll kind of get a twofer on that one. How many bend over like that to pick stuff up? Anybody? Like, come on, be honest. That's just a recipe for disaster. I mean, have you heard like, oh, my back just went out because I bent over to pick up my sock? Like, well, that isn't what did it. But how many times have you probably done that? And you probably had something already brewing. So it's just bad mechanics for the back. So learning to hip hinge, even if it's something little or like emptying the dishwasher, like you just, hip hinge should just be part of your world. And if you don't know how, we can help you with that. So it might feel foreign at first, but you'll protect your knees and your spine. Anybody in here have soft bone that they know of? Yeah, so for definitely for you guys, there should be no bending of that spine, that C, like that C shape that I'm doing. That can cause a compression fracture in your thoracic spine. So eliminate that kind of bending if you have soft bone, and you'll avoid those, because the compression fractures are usually silent, meaning you don't feel pain when you get them. So that's a big deal for those of you that have soft bone. All right. Then the other tip on there, stay neutral with lifting and exercises. Do you guys understand what I mean when I say keep your spine in neutral? Okay. So if I'm bending forward, we call that flexion. If I bend backwards, that's extension. Neither of those are neutral, right? That's two ends of the spectrum. Neutral is basically in the middle, right? So it's just basically keeping your spine straight, but not straight. Like I can't pick anything up if I'm like literally straight. So again, my spine's in neutral, meaning I'm not flexed, I'm not arched, I'm just in the mid-range. And then when I go down, I'm hinging at my hips, but I keep everything in neutral. Same thing with when you exercise, keep your spine in neutral, although I allow rotation in thoracic region. So what does that mean? If I'm standing here and my hips are forward, right? And I turn and my shoulders are that way, I'm twisted in that lower pelvis. So trying to figure out, giving you guys cues of like, okay, you can turn with the upper body, but you're going to have to keep your, like these 4 points, the front of my hips, front of shoulders face same way. So if I'm going to turn, all of that has to turn. Does that make sense? If hips are forward, shoulders are that way, I'm twisted in my back. If I instead pivot with the hips as I move my shoulders, I'm in neutral. But I can pick stuff up, move it. I can work out in diagonals, provided those 4 corners face the same direction. Does that make sense? Okay. If it doesn't, it's just one of those things in PT that we would teach you how to do, of how to stay neutral and avoid twisting in the low back. Twisting puts a lot of force on those discs. Anybody in here with a disc issue? I'm like, come on. Yep. Myself included. I'll tell you my story in the future of what happened to me. How many of you are doing sit-ups or crunches? Anyone going to confess? It's all right. I think when you see the next slide and the image of the spine, when you do a sit-up or a crunch, that's a lot of torque on the discs and the anatomy in the spine. So, I mean, certainly I expect my young clientele, right? Like teenagers, 20s, like go ahead and do the crunches and the sit-ups. But with this, the 40 and up crowd, which is probably all of us in here, you're asking for trouble. So whether that be a disc problem, straining of the facet joints, the muscles, etc. I'm fine with doing a crunch if you go reverse. So if you're already in that V shape and you want to lower down, you can keep your spine straight or neutral like I went over. But really the better option is planks. And when they actually do studies where they hook up how much muscle activation are you getting with sit-ups versus crunches versus planks, guess what wins? Planks. How many of you like planks? Good. Do more of them. Yeah, so there's a lot of variety with planks. If you've got shoulder issues, we figure things out. There's a way to kind of work around that. And there's definitely lots of core stuff to do on your back with your spine in neutral. But please stop doing sit-ups and crunches if you have back pain. That will only make it worse. So anyway, so those are kind of my like quick tips and takeaways for you to help in the moment. Does anyone have questions on that? Okay. Yes. Oh, yes. I wish I could take that machine and throw it out the window. Yeah. Yeah. I know. So if you couldn't hear his question, so in the gym, there's a machine where you have this part of the apparatus where you kind of like go forward with it, right? A little lower. Yeah, but it's yeah, you're basically doing like a crunch in a sense, right? If you could keep yourself in neutral and do it, meaning if I was doing it, don't round that spine, right? if you could do it and engage core and really keep it where your spine stays in that kind of hinge method, I would let you do it. But again, I'm going to argue that planks are going to be better than that machine. So go ahead. Oh, you want me to demo a plank? I can do that. So you're just basically on all fours, right? So that is, you are the human plank. You're like a board, right? Now, I tend to do mine on my forearms because I just use my hands too much as a PT, that I don't want to put my hands in that position. So that would be a plank. Does that make sense? Hold it. I wasn't going to stay there forever, but so 30 seconds. If you've never done them, we start, maybe 10-second holds. I also started them where I had a table over here on an inclined surface. So like your bed, you could do them on so it's not as hard, right? Because gravity, the more down you get, the harder that's going to be. You can do them on your knees instead of on your toe. Like, there's a way to mess with them. And yeah. Push-ups are great. I think everybody should be able to do push-ups. Perfect. Yep. You're just adapting it to the level of strength that you have. And then over time, could you go to a chair? Put the chair against the wall so the chair doesn't move on you. Yeah. Same with planks. We'll do people with planks on the chair instead of on the floor. Yep. Yeah.
Going on your hands or your elbows or doing an incline is one better than the other?
Hands versus forearms for the most part is really about your integrity of your wrists. And just because I use my hands a lot as a physical therapist, I'm not willing to do them there. The same amount of core activation happens. So that doesn't matter if that's what your question is. And then the incline is just less work because the angle of gravity. So if you did it on the chair, it's going to be easier than if you did it on the ground. And then you could add the ball, like wait till we add that into the mix, right? So now you have an unstable surface doing planks. So that will get more core recruitment. There's always a way to make something harder. There's always a way to make it easier. There's always a way to modify it if you've got an issue with whatever. It's really, the therapist is more limited by their creativity than anything, right? Like, we can usually find a way to work around it. So, any other questions on that? Good. Okay. Oh, yes, we are going to do the hip hinge. So that should, can you see that pretty well? So spine is straight, bend with the hips. The knees do bend, but they don't go forward like I was trying to demonstrate. I did link the YouTube link here. So when you get the slide deck, if you want to watch him do it repeatedly, you can. But I am going to have you guys all stand. So, and if you don't want to participate, you don't have to. You can sit and watch the rest of us hip hinge. So the chair is a great training tool. So the chair just gives you something to aim for, right? So you are going to try to aim your hips back towards the chair, and you're going to watch that your knees don't go forward. So I'm just going to have you basically go you can sit down if you want, or just touch the chair and come back up, but really get those hips behind you and don't let your knees go forward. So you should feel like your hips really have to go behind you to reach the chair, and that your knees don't go forward. You should notice when you do that, it's a lot of work for your glutes and your thighs, but it should take less pressure off your knees. If your back is already angry, you still might feel it there. So we'd adapt things if we needed to. But I at least want you to get thinking about hip hinging. So, questions on that? No? Okay. All right. Okay, we're gonna get into the medical approach of low back pain, okay? Hopefully don't lose you or put you to sleep. Try my hardest. So what I want you to take away from this slide is that there are lots of causes of back pain, okay? So on here, you can see the discs. right? So I saw hands go up about discs. SI joint is not pictured here, but it's very end, right, where your pelvis and your spine meet. That can be a generator where it actually can cause pain up the chain into the back. You have your facet joints. What are those? Those are right here, and that allows your spine to move, to flex and extend. And they can get really thickened with arthritis there and make it really stiff and difficult. And then, of course, the muscles aren't even pictured here, but for sure you can have a muscle strain happen. This one's a mouthful. Spondylolisthesis is basically one vertebrae slipping forward on another. So it's an instability problem. If it gets too unstable, they're going to fuse you because you don't want the spinal cord to become compromised. So sometimes this is an issue that you can't do much about. If you catch it early and it's a grade 1, grade 2, then core stabilization is your best friend. So that, depending on what level, what degree you have of that, you could have some control over it. But if it's too far gone, then you're looking at a fusion. Stenosis is basically narrowing where the nerve comes out, right? So where this, you kind of see that foramen there, that's where that nerve exits. That can get narrow, and they call that stenosis. Anybody in here know that they have stenosis? Yeah. That can really irritate the nerves. So we'll get into that a little bit more, but you can see, right, if that opening is getting narrower, that nerve is not going to be very happy. It's especially if you can think of the spine and that movement of extension, usually that bothers people with stenosis. They do not like any backward bending. So if you're doing exercises, you should probably avoid extension if you have stenosis. I would never give anybody with stenosis extension. Maybe in the upper back, like that would be fine, like posturally up there, but not in the lumbar spine. You'll just tick everything off. So if you really love yoga, I've had to modify routines for that. Like I like yoga. It's just like it's got to stay all in the thoracic and chest, but nothing in the lumbar. Compression fractures, most of those are silent. I'm not going to go into why, but there's a lot of reasons for that. But you could end up with a compression fracture in the vertebral body. It's usually soft bone or trauma. And then the hip. So sometimes the hip is actually the culprit causing low back pain. It usually, I list it last primarily because it's rare that that's the reason. But I already talked about stiff hips playing a role into the low back. But sometimes you can have a degenerative hip that's actually causing the back pain. All right. This picture I also like because if you have any bone spurring, can you see how that, I don't know if in the back if you can see that very well, but you'll get the slide deck. There's kind of this thickening of extra bone spurring happening there. And if it happens by the nerve, what do you think the nerve does? Yeah, it's not happy. So that's what this is showing, just irritation of the nerves. And then if you have a disc, like a degenerative disc, does anybody know if they've got degenerative disc? Yeah. So you just don't have, like this is, a nice, thick, healthy looking disc. And you go down to this one, there's hardly anything there. So it's just more prone to aggravating the nerves. And if you think about just the different rotations and movements and things that you do through the day, it doesn't take much to set that off. So, questions on that before I move on? Sure. Mm-hmm. There are places that do disc replacement. You have to fit certain criteria for that. So that's different than what you're talking about. I'm not sure in this area if anybody's doing what you're talking about. Like it would be something you'd have to investigate up north. And I think you have to have if you're going to do it at that level, what are the levels above and below like? So there's strict criteria for stuff like that, but certainly options to pursue. Yeah. And then if you have a compression fracture, they'll also inject stuff in there to try to get that vertebrae to widen up too. So yeah, so there are some options. Obviously, I'm not a surgeon, so like I don't know all the surgical options out there, but they are. I mean, there are some for when that disc completely is gone. I'm going to keep going. All right, this is the disc page since we're on that topic a little bit. 60% of asymptomatic people have a disc bulge and 30% have herniation. So what does that mean? If you take a bunch of people off the street that are not having back pain, they are not having sciatica, and you give them MRIs, 60% of them have a disc bulge and 30% have a herniation. So keep that in mind. If you have symptoms and you get an MRI and it says you have this, could it be plausible that you have something else also causing your pain? Yes. So on here, stage 1 and 2 are kind of those protrusions, right? And then 3 and 4 is the herniation, where the part of that disc material is herniated out. And if you can go back to that other slide where the nerve was, you can see if that happens, like that's really going to irritate that nerve. So that happened to me. I was all the way here in 2013. It was a result of an old injury. I played collegiate tennis, and I had a bad habit of hitting the ball late. And when you hit late, you twist. So you add up however many repetitions of that I did over time. So in college, I did have a couple injuries, and I was probably in this camp there. And then you take an aging spine with that, active, running, ran a half marathon. I did pretty well, but 2 weeks later, that's what happened during the race, but I actually didn't feel anything until 2 weeks later, and then all the nerve symptoms came on. So those of you in the room will get to sciatica and nerve stuff, but keep in mind when the symptoms come on, the damage was probably done 2 to 3 weeks prior. And that's a real hard thing for people to like wrap their head around. It's like, I didn't do anything. And then I have to talk to me about the last 30 days, everything that's happened in the last 30 days, because something in there did it. Because the nerve symptoms don't show up right away. So I had a huge herniation. It was one, I don't remember now if it was, I think it was like 13 millimeters, which falls into very large. The neurologist is like, I don't even know how you're walking around. I'm like, what choice do I have? I have 3 boys. I run a business. Like, this is what it is. And I'm not taking that stuff. So I had a choice of like, okay, get an injection. You can wait this out, or you can have surgery. We'll go in and scoop that out. And as a PT, like having surgery on your spine is the last thing I thought would happen to me. But I chose that because it just was too huge. Like, your body can absorb the herniated material over time, but it probably would have taken 10 years. So when they do studies and they look at the people that have the discectomy and the people who choose not to, functionally at 10 years, they're the same. But in that 10-year time frame, I would have been absolutely miserable. So as soon as surgery was done, I was fine walking around, felt great. But it's just kind of to highlight, depending on what's going on, sometimes surgery is indicated. Like, I'm not for sure I want to avoid it anytime possible, but I'm a walking story of like, I had to have it done, still here. So now I'm in the camp of there's no disc left between L5 and S1 for me, like 0. So I've confirmed that with x-ray, and from time to time it flares up. I'm just waiting to see like, all right, how long do I have before I have to have anything else done? So the regenerative stuff is keeping me going, and my core routine and my stretching routine, all the stuff I told you on that other slide, I follow to a T. All right, questions on that slide or any disc stuff before I move to the next slide? Go ahead.
What happens over time if you do
Usually with a microdiscectomy, there's no hardware going in, right? They're just taking out that herniated piece. Usually people do really, really well after. I think it really matters what the person does the first 6 months. So meaning like, I'll never forget when the surgeon saw me at 3 months. And he knew I was a runner. He's like, Jennifer, you go run. I'm like, no. Thank you, but no. I mean, he was confident in his surgery, which is fine. But I also knew about tissue healing, and I'm like, I am not going to do that to this structure when I haven't strengthened it. All I'd done was walking at that point in basic, very basic core, nothing crazy. So I was very careful with my loading so that I didn't tick anything off. So I got back to running by 6 months, but he was like, go ahead, do whatever you want. I'm like, is this what you tell your patients? I mean, obviously. So I did fine. I've had some flare-ups along the way, depending on, when I travel and, you're sleeping in wherever, traveling on planes, like there's stuff that will make it irritated, and I just know how to deal with it. And I'm also using some of the regen therapy stuff that I'll get into tonight. So by and large, people do pretty well with the microdiscectomies. It's just that when that disc is herniated out, think of toothpaste. When you squeeze toothpaste out of a tube, are you getting that paste back in the tube? No. So when that happens to the disc, now it's shrunk, and there's nothing that material had already left my disc. It was a lost cause. I wasn't getting that cushion back. So there are some surgeries now that weren't around when I had mine, in terms of what she was bringing up earlier about injecting some stuff in there potentially. I'm not having any symptoms right now, so I'm certainly going to leave well enough alone, right? So we'll see if I have to navigate what's next for me. What I do know is with no disc there, that shrinks where the nerves exit L5S1, that foramen, that now there's less room for those nerves on both sides for me. That if I get symptoms down my leg, it's not like I'm worried, like I know what it is. Can I calm it down? Or is the bony structure getting so narrow there that it's a structural thing that I may need to have? I call it the Roto-Rooter procedure, where they go in and they widen where that foramen is for the nerve to be happy. But again, I wouldn't be getting hardware or a fusion. I'd be dealing with the bony structure that's hitting on that nerve. So similar, foraminectomy, laminectomy, that just they're going to remove some bone to make more space for the nerve. And if you don't have soft bone, I think that's a viable option, right? Because if you soft bone, then like, what if you collapse the area? Then you're just headed towards a fusion. So it does compromise the integrity of the area, right? Because you're taking stuff out that should be there. So I don't know if that's in my future, but I'm well aware of what could happen. So that was 2013.
I actually had that procedure. That's something that I was worried about.
I wouldn't worry about it. I think being aware that that's a possibility, but in the meantime, what can you do to optimize your back? It would be my stance on it. And I mean, like I said, I've had some flare-ups, but navigated them. So don't worry. Just be aware is how I would reframe that. Yeah, I mean, we'll go into that more. Yeah. We'll go into that more. Yeah. Yes.
So to determine this stuff, is an MRI needed, or can your team evaluate that? Oh, you probably need surgery and you probably need an MRI.
We will level with you if we think it's a surgical case. Now, our bias, of course, is to try to get your body to heal, and we have some technologies to help jumpstart that, right? But I have had people come in and they had a herniated disc and they had drop foot, meaning they couldn't pick their foot up, and it was acute onset. And I was like, you have a huge herniation in that spine on that nerve. A lot, like think of all that toothpaste out of the toothpaste tube that's sitting on there. All the stuff we could do really well is not going to remove, like go have the microdiscectomy, have them take that out so that the nerve doesn't have pressure on it so you can function again. So we will level with, if we think it's a surgical case, we will tell you. But know that our bias is to avoid that.
But there are some ways to tell without.
Yeah. If you're having extreme neurological deficits like drop foot, it's probably a surgical case. Yeah, yeah. Yeah, but we do the same, the tests that the orthopedic surgeon does and the neurosurgeon does, we do. They're called special orthopedic tests, special neurological tests. We run through the gamut to find out, are you appropriate here for PT, or do I need to refer you out? Like, that is part of our ethical obligation to figure out. And we have no trouble sending you onward if, like, yeah, this, if I don't feel comfortable, if I need an imaging, I will say it. So, yep. We want to help you, whether it's us or whether it's somebody else at the end of the day. All right. Does anyone else have a question on that? No? Okay. All right. What's actually causing your low back pain? But I hope you kind of got that from the other slide. There's a lot of structures that can cause low back pain. It's rarely a single cause. So it's almost always a combination of structural changes, right? Whether that the degenerative changes, bone spur, nerve involvement, and tissue level, and then cellular level inflammation. And maybe you haven't heard that term before. Just let that sink in. We'll get to it. Two of the most overlooked generators that we have, subchondral bone edema. So when you have arthritic changes, I don't really care if it's your back, your knee, your shoulder, your ankle. If you have arthritis there, you're going to have bone edema. And that definitely causes pain. So there's fluid and inflammatory changes that happen underneath the cartilage. Like, everybody's heard arthritis is when it's bone on bone, right? Cartilage is worn away. Like, everyone's heard that term. But I don't know that people have heard that the subchondral bone has actually got edema in it, and that is creating a lot of pain. It will show up on the MRI, whether or not the doctor tells you that that's there. Some do, some don't. And then the neurogenic inflammation that surrounds the joint, right? Everybody know, like with arthritis, I think you guys all know, like, it swells, there's inflammation there. So that's really the pain generating aspect of the arthritis, or I think kind of just overlooked as that edema part in the bone. So the pain that you feel isn't just structural, right? It's driven by the inflammation and definitely at the cellular level. So that's something just to kind of keep in mind as we go through some more of these slides. Sciatica. How many have been told they have sciatica, or you know you have sciatica, right? So sciatica, all that means to me when I hear it is just like, okay, that just means they have pain in their leg. It tells me nothing of where it's coming from. So it could be pinched at the spine level, right, that you saw on the earlier slide. It could be somewhere else in the leg in terms of the entrapment. So whether the piriformis is grabbing that nerve, the sciatic nerve. So it doesn't really give me, is it disc? Is it a bone spur? Is it muscle? It just tells me that there's pain in your leg, right? And so we do a combination of tests to figure out where is that coming from, okay? So herniated disc or stenosis, piriformis, scar tissue, degenerative changes, something along those lines is hitting that nerve. Lots of people are told that surgery is their only option, but often it's not. However, I already went through, like, large herniations and structures pressing on the nerve, it might be a surgical candidate. And the nerve itself can be treated. So I think that's something that's new that people haven't heard of before, and I'll get into that, without injections and without surgery. So we have a device that uses pulsed radio frequency, and it used to only be available in the surgical suite. So if you tell your doctor you're going to come to Penrose PT and get pulsed radio frequency and this device called StimPod, they're just going to stare at you like, what? And if I try to bill that code, it's a code that's in the surgical suite. So what do you think happens when I try to bill it? Right. They're like, why are you billing a surgical code? Because that's where you've put it, and it's now available in a device. And so I get asked a lot, will they pay for it? Typically not, but it is available, and it does help with regenerating that nerve. We'll get into that a little bit more. So traditionally, and I think most of you in here have probably been down this road a little bit, you know, with back pain, rest, pain medications, or the anti-inflammatories like ibuprofen, cortisone injections. I'd really caution you on those. Cortisone, you can do your own research on PubMed, but it is damaging to tissue and can cause osteonecrosis of the bone. So be careful. Anyway, that's all I'm going to say about it. MRI, and often if they find something structurally, then you're going to get referred to surgery more than likely. Other traditional things, yoga, Pilates, PT, core, and I am all for that. Obviously, we're a PT clinic, and we do think there's a lot of importance to getting that part right. The thing that we do a little bit different, we often find multiple things that are causing your pain, and we're going to address all of them. And then I think the big thing is just we treat the inflammation at the cellular level with some of our technologies, which I'm going to get into, and then target that nerve directly with that pulsed radio frequency that I talked about. And then we definitely don't overlap our patients. So I don't know if people have been to PT elsewhere, but we are one of the few clinics where when you're with your therapist the entire time and you're not overlapped with anybody else. So kind of a little highlight of just our way. So here's one of the technologies I want to get into. It's called EMTT. It stands for extracorporeal, which means outside the body, so nothing's going in you. And then magnetic transduction therapy. So it's about half the strength of an MRI. And it basically targets at the cellular level in terms of decreasing swelling, decreasing the cytokines and the inflammatory markers. I think the biggest name, if you're into reading research, is Dr. Gertesmeyer. So he's a German orthopedic surgeon. So he's done probably thousands of total hips, total knees, shoulders. I've seen him speak at the regenerative conferences I go to. But I think the big thing that was really neat is to hear him talk about in Germany, when patients are waiting for a total knee replacement, he did EMTT on his patients twice a week for 4 weeks, and over half of them canceled their knee replacement. So this stuff really does work. I'll show you a couple slides coming up. It'll be pretty cool. But it penetrates pretty deep. It reaches bone, cartilage, the joint. No surgeries, no needles, no downtime, and we have it. It really is great with dealing with that subchondral bone edema that I was talking about. And I'm going to get to a slide on that in a second. I already talked about that. I'm going to skip through that. This is a picture of the hand piece where you just set that over like your knee or your back. And that's just trying to show, the red is just trying to show the magnetic waves there. It's a high oscillating magnetic field, great for inflammation and pain. Great for bone healing. It will heal fractures in half the time if you're doing that a couple times a week. So here's the MRI I wanted to get to. So this is a patient's films. This is a herniated disc, and I think you can all see that there. If not, like I said, you'll get the slide deck. And then this is a cross section through the vertebrae, the bone, and that white, all that white is edema. So then those are, that's definitely driving pain, that and that. And this person did EMTT twice a week for 4 weeks. 3 months later, they did an MRI. You barely see that disc herniation now. And then that white is all the way down to like that now. So the herniation reduced and the bone marrow lesion significantly better. Now, that was 3 months post, right? We did, the treatment is just 1 month. So the protocol is twice a week for 4 weeks, but your body is still healing the next couple of months after. When people start EMTT, usually they don't see a huge reduction in pain until like week 3. And then it really takes off after that, even though you've finished getting the treatment. Anybody have questions on that? It's magnetic therapy that causes it knows which cells in your body are not working right. So it just targets where the inflammation is. And especially with bone, it stimulates the osteoblasts to form. If it's tendon that's a problem, it's going to stimulate the tenocytes to form and heal. But the big thing is it really shuts down the inflammation process. So like the cytokines, it really drops that. So the biggest thing to use it for is swelling and for bone healing. Like if you had to pin me down on like what are the two top things that it does. So that's why with arthritis, it's amazing. Yeah. What?
Cartilage, does it stimulate new cartilage?
Yeah, so interesting. I was in Boston in March at the Regen conference listening to the Harvard and Mayo doctors, and what they're finding is if somebody does EMTT, I'm not really talking about shockwave tonight, but these individuals are doing both for, let's say, knee arthritis, right? And they're doing it on a 6-month regimen, like every 6 months they're getting treatment for about a month. And what's holding steady in the radiographs is the arthritis is not advancing. It's just stabilizing, right? But the individual, their inflammation is way down. They're playing pickleball, golfing, whatever it is that they want to go do, they're doing. So functionally, the patient's like, this is amazing. And then the orthopod is tracking the films and seeing that the degeneration is halted, right? Right. So it's not getting worse. So they believe what is happening with the cartilage is that the cartilage is becoming a healthier version, but it isn't necessarily generating new cartilage, right? So that's been a common question at these things. And so it's just the MRI, when they look at the T signals, what they call it, it's a healthier signal after this treatment, but they can't say for sure that the cartilage is really regenerating. They just know that it's healthier. So it's a debate. There's some people in the room there, they're like, oh no, it's definitely regenerating. And then there's some of us in the room that are like, I think it's just a healthier version. And I mean, I'll go next year and see if anything's changed, right? Like this is a rapid changing field, but I'm blown away by the result. I used to joke that I wanted a magic wand, and now I have one. All right. So, I mean, just kind of what I can tell you with patients using it, right? So when they get it, they just really feel like the inflammation goes down. They have less achiness, less stiffness, less morning stiffness, less flare-ups, just reduced need for medication. In Germany, they're using it as a standard of care in the hospital after a total knee, and that gets their inflammation way down, which then your range of motion goes way up. You get off the pain meds faster. You leave the hospital without any pain meds. Like, all right, this should be happening here, but not yet. All right, so I'm going to move into another category, which is very similar, right? It's still electromagnetic therapy. So there is what we have, a pulse EMF. So the studies are linked at the bottom of these slides if you are into reading those. But for low back pain, this is 420 patients across 9 random controlled trials, right? Their pain went down, mobility went up, and increased lumbar range of motion. And really the best combo is using the EMF with PT, right? Like doing core and stretching, etc. So that's another aspect of what we have here that would help with low back pain. And there's some research behind it if you're into reading that. How does it work? So those of you that really want to nerd out on science, right? So it targets these pathways, which are the root chemical drivers of nerve irritation. So those of you asking, like, how does it work? It works at the cellular level. And if you really want to nerd out, go for it. It clears the inflammatory byproducts, right? It boosts the blood flow, and it just allows the cells to repair and cleans out the stuff around the irritated nerves. Those of you that have nerve pain, you want that stuff moved on out. And so this is a great way for that to happen. And then it just activates your own body's repair mechanism to stimulate tissue repair. So that's The easiest way for me to explain it, if you really want to geek out and read the science part, you can. All right, I'm going to move to the last thing, which was the pulse radio frequency, which I talked about a little bit in terms of it being a surgical suite code. But again, this radio frequency, what it does is it targets electromagnetic energy delivered to the nerve. So all three things that I'm talking about tonight are electromagnetic, yes? So they're just different forms of it and different intensities of it. So this is great for pain management for nerves, and it does regenerate the nerve. Nerves do have the capacity to heal most of the time, but they heal very slowly. So if you have a disc problem where that nerve goes all the way, the irritation goes all the way to your foot, measure that distance, and this is the rate at which it will heal. 1 millimeter per day or 1 inch per month. But with the stim pod, we can get this done in like a month. That should really blow your mind a little bit. So it basically modulates the nerve. The nerve is just freaking out, is how I like to explain it. And this just kind of gets it reset. It's almost like rebooting your computer. It reboots the nerve. It kind of calms down its hypersensitivity. The stim pod itself can be a little bit uncomfortable, but it's not bad. Certainly not invasive. It's not like an injection or anything. But it's great for sciatica, any kind of pinched nerve from the spine down the arm or leg, peripheral neuropathy, nerve entrapment, post-surgical nerve pain, any of those kinds. And there's other wacky nerve things I've been using it with, like trigeminal neuralgia, burning mouth syndrome. I hope you never get to experience that because it's really awful. But I'm playing around with using it with other nerve stuff. So who that's for, the stim pod, kind of went through that a little bit. Sciatica, neuropathy, nerve stuff. I'm going to just, try to keep going here. Again, PT is really, really helpful on its own. It's just if you want all these other things, it can get you better faster. And then there's just some things that are available now that weren't available before. So I'm going to just keep going. Yeah, the last part here is the handout that you got tonight. You should fall into 1 to 2 categories. If you have back pain and sciatica, my recommendation would be to get a full PT evaluation so we can really delineate what is causing it. And know that we'll probably recommend either one or all of the technologies I talked to you about tonight. I pulled the 3 that are most pertinent to low back pain and sciatica tonight. We have other things. We also have dry needling for like tension, if it's really more of a muscular tension thing. But I try to just kind of focus on those main 3. If you've already done physical therapy and maybe you're already in PT somewhere else and you just want to have a consult about the advanced technologies, the regen stuff, I'm happy to do that. So that's usually where the 2 options that people fall into for coming tonight. So if you fill that out, want to give it to me, I think I still had a bunch of copies of my book that I was handing out. I don't know where Noble went. Maybe. Anyway, but I'm happy to give you a copy of that. And so now at this point, I'm just going to open it up to questions because I think we made it through everything. Questions? Go ahead. Do you want to bring a stack of them? Yeah. So the question was, do you need a referral for the regenerative options? No, you do not need a referral for those. Like if you wanted to talk about the stim pod, the EMTT, the pulse PEMF, you do not need that. If you want physical therapy, then that's usually payer specific. In the state of Washington, you can come straight to a PT without a referral. Yep. However, if you want your insurance to pay, they often require a referral. So it's insurance dependent. Medicare needs your physician to sign off on the plan of care. So we often just tell you it's just easier if you get that referral first. Otherwise, we have to chase them down for their signature. So does that help answer that? Okay. Right. You don't need a referral for the other treatments because it's not, yeah, those other things are not covered by insurance. Typically not. Like if we've had a few Shockwave has been covered by VA under very specific parameters. Like you've had to have suffered for 6 months with plantar fasciitis and then they'll pay for it. Yeah, so it's I laugh because I'm just like, okay, yeah, sometimes, but yeah, it's not by and large, no. Most of them do not. Yeah, and you can even with your own, like if you have Regents or Primera, you can look up on your benefit booklet online, and you will find out pretty quickly. I mean, I know Regents and Primera both put most of the stuff I have into investigational, which just means that they don't feel like there's enough research yet to pay for it. How much research do they need? I don't know. I tend to be a little bit, they want to pay for less, not more. So I guess I don't know if they ever will. Maybe. I don't know. I don't know. So, yeah. The EMTT and the Pulse PMF and the StimPod, the technologies, basically. EMTT was what I talked about with the electromagnetic transduction, where I threw those images up of the MRI showing the bone edema and the disc herniation going down. Basically, the regenerative therapies. It falls into the same category as like PRP and stem cell, these technologies. So regenerative medicine, and by and large in the United States, is not covered by insurance. There's a few things that they will, but not a lot of it, as you probably know. Perfect. So there are packages and there are plans to make it more affordable, especially if you're going to do more than one of the services. It's almost like getting buy one, get one for 50% off or more. So it really depends on what all you are wanting. So we have a premium recovery plan, and that's $1,600, but that's going to give you access to like a variety of things that would be probably triple, if not quadruple, what that price is. If you just wanted me to say like what it is per, if someone was just going to come one session at a time, it's $250. So that's why the package pricing makes more sense. And we tried to do it where people feel like they can get a variety of those technologies for at a more affordable cost than trying to like add it all up together. Because usually if you have a pinched nerve, EMTT to the spine and then StimPod to the nerve in your leg and the pulse PMS. So that's 3 different things. Well, 250 times 3 for one visit, that's a lot. Might as well just do 1,600 for an 8-week period where you're going to get all of that. So, yeah. And we would definitely level with you if we thought you only, there's been a few people where I think they only need one option. And so there's a package pricing for that would be better. So we'll tell you which one is really going to be your best option. But if you're doing more than one of those technologies, the premium plan is going to be the best option for you. What's that? Yes. Yeah. Yeah. The evaluation is really going to give you a full detailed picture of what is going on. And in that is going to include some things that you can do on your own at home, how to modify your workouts if you're doing other things at the gym or playing golf or pickleball or whatever it is you're doing. Getting that PT aspect of it, the most successful plan is to do both PT plus the regenerative options. I mean, how fast you want to get better would be how I would pitch that. I didn't have that stuff available when I had my back issue, but it wouldn't have helped. I still would have needed the surgery, but my recovery probably would have gone faster. My neck injury that I had, I guarantee you, with the tingling and numbness that I had, it took me about 3 months to get over it. And I was doing massage, physical therapy, dry needling, and I was being a good patient because I wanted to get better. If I would have had this stuff, I think I would have been solved in a month. So 30 days versus 3 months, right? So it just accelerates your healing. You feel better faster. So, yep. And just options that are available now that weren't available then. So, I think it's always a matter. People ask, how successful is it? Most of this stuff has an 82% success rate, but that leaves 18% where it's not. And I think some of the question is just how much progress will you have? You may get full resolution, you may get half, you may get 25%. It's hard to know until we go down this road together. But the results that I'm seeing are outstanding. I mean, it's been pretty amazing. I've had a friend with peripheral neuropathy that she had it for 12 years. We did the stim pod for a month, completely resolved it. And that was over a year ago. It's still completely resolved, has not come back. And it was induced by chemotherapy. So she had peripheral neuropathy in both her feet from the chemo. And she's doing great. So I've had people with nerve injuries that were 10 years old and they got all their grip strength back, their sensation. So those are like the highlights. Certainly I have some where like it only helped by 50%, but they were so grateful. Like one gal described it as, I was walking on broken glass before and now I'm walking on cotton. I think cotton sounds better than broken glass. So, I won't overpromise. I usually just tell it how it is, and we'll see. It's a journey, and we'll see how far it takes you. So, yep. Any other questions? Say that again. I am so sorry. Is there a dark cloud following you? Yeah, I think when people have multiple things, we try to start with what is impairing you the most right now. What is like high, like let's rank these in order. So that might just deserve a discussion at the eval of what is bothering you the most, like what's affecting your sleep. I always care about sleep because you can't heal if you're not sleeping. So what's impairing your sleep the most, and then like just daily activities like getting dressed. So what things scream at you with just the basic things of life? Like let's deal with that first, and then we'll deal with these others. So we'll just tackle it one by one. So yeah, we can do them all, but we often will do, if someone has multiple body parts, and I get it, you guys are frustrated, you're in pain, you're dealing with a lot, and then my front desk will be like, well, we can only evaluate one thing at a time. Take it with a grain of salt. Just come to the eval. We'll help pencil out what's priority for that day. And maybe we book you a couple weeks later for a different eval of the other body part. Because when you're here, if I'm only giving 5 minutes of attention to like 5 different things, we will make no progress, right? So let's deal with the worst thing, get some headway on that, and then we'll deal with the next thing. The great thing is that the Pulse PEMF is a full body mat. And when you lay on that, you'll feel it where you need to feel it. And then you can take the paddles and put them you can give concentrated focused PMF to the area, and you can move it around. Like you have at it for 20 minutes. So you can kind of treat everything with that device, that then if you're just being seen, quote, for the shoulder to start with, you could still get on that and move the paddle around wherever you want. So, but you're not the only one that has multiple body parts. So we all have a couple things brewing in the background. It's just what degree, myself included. Yeah, anything else? Okay. Thanks for coming. If you fill that out, I think nobody